I think the first challenge is the way we do our programming. Most of the time we do our programs assuming that one, that women have the power to negotiate what it is that they want. Secondly, and let me just give an example. An example is that that a woman can get up in the morning and decide to go for PMCT or for treatment on their own. That a woman can decide that she wants to go and give birth in a clinic on her own. That a woman can be able to get herself home without any assistance from anyone else. So I'm talking for the majority of women who live in rural Africa. The assumptions for most of our programs is that women are empowered enough to make those decisions. That's really not true. The majority of our women must still rely on someone else to get them to the clinic on time, must still rely on someone else to agree for that cow to be sold for them to get that money to go and be able to get to the clinic. The other issue is if she gives birth at night, how does she get there? So I think a lot of the times our programs assume certain things around what a woman can be able to do to be able to go and give birth. When I also look back at my community, most children who are born either premature or born in a place where there are no facilities will die anyway. So the priority for a child being HIV negative is really not a priority unless you can ensure that each child has a right to be born and not die. So the premise first is a child being born and the right to live, and then the HIV positive then comes in. So layering this one on top of a problem already is actually it already creates a conflict there. So for me, really, that's why I said my first commitment was to the rights of children. And then the second commitment is to a HIV-free generation, because that's the only way it will happen. And obviously the third thing is poverty, general poverty, commitments by government to, because even if I fund a donor program to make sure that women get to the clinic on time, right now in Kenya, the Clinton Foundation has been supporting HIV treatment for children throughout. If they close next year, I can almost guarantee you that there will be a gap. So for me, those gaps are, why should there be a gap when it comes to something that we know that the children will have to be on treatment?
I think we have some systemic challenges in terms of logistics, getting the testing facilities to be operational, to be available across the country. We have a challenge of human resources in the health sector. But then we have a challenge of money to ensure that all the necessary ingredients for a successful PPTCT program are in place. I also think that on the demand side, we have a couple of challenges, like not enough mothers, pregnant mothers, are reporting for antenatal care. Not enough of them are delivering in health facilities, and it becomes impossible to administer the necessary doses for PMTCT if institutional deliveries are insufficient. So I think we also need an aggressive social mobilization strategy to ensure that all our mothers, pregnant mothers, are able to deliver in facilities.
The major challenges are, like our chair said, the political will. I believe that nothing is impossible if there is passion to end it and commitment. It's not always about funding. It's about the commitment. That commitment has got to be there. That's when you come up with all sorts of ideas to be able to find solutions to all the challenges that face you. So once we have that commitment, we can make it happen. It may not be today or tomorrow, but as long as we start the process, it's bound to happen.
There are many challenges, whereas there's guidance being developed on how we can actually implement this new evidence on prevention of HIV infection in children. The actual implementation has been a major challenge due to the constraints in health systems and in human resource capacity. I think the infrastructure and human resource capacity are the biggest challenges to the implementation of this new evidence.
The main challenge to achieve this goal, first, is the commitment of the government for this to achieve this goal. Not only in terms of funds to reach 15% according to our budget declaration, but the involvement of the government, the involvement of all structures of the government to reach, especially the poor people which they have never been able to have good package on health facilities. Until now, we are working in the cities, around the cities, but the people who more need our support, who are in risk, we are able to reach them. And this is time to start to do this kind of work.
There are many challenges. The main challenge, the way I see it, is the financial and the management, the managerial of this finance. Even if we had the little finance of financial capacity, but we need to manage it properly in order to have all the system work. Because, for example, in my country, Tanzania, we seem to have very good systems on the book, but the practicality of it, we have just about 12% of the children in Tanzania receiving ARTs, whereas we are told that we have all the, adequate facilities to provide these children with the ARTs. So I think it is very important that we have adequate money, but also we manage the systems well so that we can make a difference.
Well, the main challenge is political will of our leaders on the continent. They need to make sure that pediatric AIDS is put on the top of the health agenda, of the national agenda. And we need to give them the necessary information that this investment now will be an investment that will benefit the countries in Africa because an AIDS-free generation would be able to work and would be able to contribute to national development and would be able to be part of a strategy to reduce poverty on the continent.